The COVID vaccination enhanced service is now out and available for you to have a look at. You've got a few days to decide if you're a practice or network looking to take this on. And to try and help you do that, I'm going to go through the exact specifications, the letters that we've received that explain the whole process, what you do and don't need to do, and what you definitely need to be aware of. And I may give you a little bit my perspective, but I'm going to try and avoid doing that. This is more about information that you need to know to do the enhanced service if that's what you're planning on doing. So make sure you stick with us. I'm recording this live, so please be forgiving if I make a couple of gaffes going through this one. Make sure you subscribe, like this video if you find it useful, and let's tech enhance your primary care and learning. Shall we begin? So let's get cracking, EGP learners. In order to help with this, I am going to share my screen so you can have a look and see what's going on. Effectively, we're going to have, there we are. No, wrong one. So this is effectively the document that we've got from NHS England. I think there's key things you need to be aware of. There's two main documents that you need to have a look at. So there's the vaccination program, the next steps document. So this is a summary kind of letter and taking in some key points that we'll cover in a second. And then there's the enhanced service specification document. This is 29 pages long, and it's got all the detail of what you need to be aware of when it comes, and it's effectively the enhanced service that you're signing up to. So we're going to have a look at that second, but let's have a look at the first letter. So this is one that basically explains the main process and stuff. And there's various different parts you need to take into account. It basically explains that you have until basically midnight on the 7th of December, midnight on the 7th of December to fill and apply for this, and you have to do this in writing to your CCG. So you don't have a lot of time. You need to get cracking with doing this. There's further details in terms of what the documents need to be aware of and what they're expecting in terms of the site designations and further documents. Do have a look at those if you want to have a look at what's going on. It then talks about Annex A, and we're going to cover that in a little bit more detail in a second and what that entails. Key things. So it does talk about the fact that there is an expectation that you should be able to deliver the vaccination between 7 days a week, and on Christmas Day and the bank holidays. Now, this has been covered. This doesn't mean that you have to be open at those times, but you need to have the capacity to be open because of the vaccination delivery schedules and that kind of stuff. So if you get your delivery on Christmas Eve, for example, you've only got 5 days to use them. So you do need to be able to vaccinate. And if you're shut for the bank holidays, then they're just going to go to waste. And what they're keen to avoid is wastage of the vaccination. That does have some connotation, and clearly you need to take that into account with how we're going through things, and also making sure you signed up to the bulletins and things. That's that letter in basics, but like I said, we do need to go through Annex A, and Annex A talks about various different aspects about the enhanced service. The first part talks about estates, and this in particular makes mention of the fact that you should be using primary care estates to try and deliver the vaccination. So this is ideally practices. If that's not available, vacant NHS sites that CCG may have access to, and these should be provided free. However, there's the clear recognition that there may be some areas where there just isn't NHS estates available for you to do this. So therefore, there is a fund of £20 million available for CCGs to support you with in terms of initial costs and stuff. And it does give some of the details of what you need to be aware of. And it's mainly for one-off costs rather than room rental and that kind of stuff, although that is taken into account. It does comment about how the various different aspects need to be looked at. So per meter squared in terms of cost equivalency. Looking at the size of the venue, so it shouldn't be too big, and clearly it shouldn't be too small for particularly social distancing and that kind of stuff. And also that actually, if you're a PCN clinical director or somebody else involved in the NHS that's going to benefit from that particular contract, that's not allowed either. It does mention about the license being available till the 31st of March and potentially longer if needed, but that's the minimum requirement. And that trying to avoid too much cost, basically, so not trying to make too many amendments, dilapidations, all that kind of stuff. So it talks about the estates in that area. It's got reasonable information there. I think there's enough there for people to get started with. It does mention later, talking about CQC registration. So once you've got your site that actually needs to be CQC registered, if this is an existing practice or NHS property, that shouldn't really be a problem. However, if it's not, then clearly you have to go through a process, and that process is through the link there. So if you are having to do that, make sure you've done that process, because clearly you do not want to not have a CQC registered site, because then you have more headaches to deal with. Equipments and consumables and the vaccine supplies. This is section B of Annex A. It's going to get a little bit complicated, I'm afraid. It does give the list of the equipment that's going to be provided for practices, so make sure you have a look at that and you've got all the equipment that you need. It does state that PPE and all the other kind of stuff that you will need for vaccinating patients will be provided through the portals that already exist, and that practices shouldn't really be having to transfer equipment between themselves and vaccination sites. So there is the hope that all that stuff will be there. Additionally, you'll also be getting hard copies of patient in service leaflets and all that kind of stuff that practices will need to give to patients in order to help with things. And that's pretty much all the B kind of area in terms of equipment and that kind of stuff. The next part it does talk about is data payments, bookings, and all that kind of stuff. Now, recording the vaccination is something that I know many people have been really worried about, particularly the systems we may have to use. It has been made clear in this document that it will be Sonar that's being used in London and Pinnacle for the rest of the country, which is what pharmacies use to record vaccination services. And I think that's mainly because of the interoperability, as well as just making sure they've got a unified record across the entire country, so not just primary care. It's a web-based service, so you just need internet access to do so, and the cost of using it has been covered. But you will need, obviously, internet access to do so. Couple of other things you're going to need. So you are going to need a barcode scanner. This should be on the list of equipment that's provided for places where they're setting up vaccination hubs and stuff. But just to be aware, you will need that because you have to scan the barcodes of the vaccine in order to register them. Interesting piece of information. I've heard the first batch may not have barcodes, so that's going to make that a little bit interesting if that is the case, but that is a rumor. No, definitely not confirmed. And one of the bigger concerns was obviously we're not using the GP records, that how we're going to do reconciliations for costs and for claims and all that kind of stuff. The data extractions should work that through Pinnacle and Sonar, that it's done within a 24-hour period. It's automatically reconciled with the GP records. So that information should come to the practices. And if you did watch our System 1 update that we had last week that talked about this, that System 1 at the very least, and I'm assuming EMIS as well, are working with obviously these systems to automatically file those so that you shouldn't have to do anything unless there's been an issue like allergies or that kind of stuff that requires clinical input. So to make that process easier and to reconcile it within that 24-hour period so that that process is covered for you. It does mention a little bit later down about cash flow, because that's something that many people have been concerned about and stuff. And that is a bit of a concern, I must admit. So here we are. It talks about cash flow, where the PCN, the groupings, are concerned about this, and that they will take action to ensure that appropriate for cash flows to practices. This is partly because, as you know, the payment for the vaccine will be based on the second dosage, and there are going to be exemptions. We'll come to those later in the service specifications, but that you basically won't get paid till much later down the line. I'm slightly concerned about that line, I must admit, because it says that action will be taken, but it doesn't specify what type of action and how that will be reconciled. That is a big issue, I feel. So I think that does need a little bit more detail. I'm assuming some of that will come through in some of the webinars that I know NHS England are planning in the near future. Call and recall booking system, so this must be done locally and effectively to support things, and you can use the softwares that you're probably already using, so that doesn't require a separate system. You could, I believe, use the national ones that are being offered to mass vaccination sites and stuff potentially, but obviously there may be a cost attached to that. Workforce planning, so there is an element of trying to figure out how to do this, and there is some elements of creating additional staff. I'm going to try and zoom in so you can see this a bit clearer. There we go. This is the list of the type of staff that you can use. There are two different sections. So there's different categories. So experienced vaccinators, so these are people who do establishing already vaccinations. There's a group of staff that can vaccinate with training. So they potentially may need additional training in order to be able to vaccinate. And these are potentially a lot of the ARS roles, as well as other kind of new to general practice roles that we've been using. And then there's an additional non-healthcare worker cohort that will require legislative changes in order to allow them to vaccinate. The key thing here is this actual category here, the registered healthcare professional. So these are the potential groups that can be able to do things like consent and that kind of stuff, as well as vaccinate, as far as I can understand, compared to the healthcare and social workers are the not registered group, because they won't be able to specifically do the consent, and in terms of vaccinating and doing a lot of the administrative stuff like the drawing up and stuff, they won't be able to do those independently. However, they could do those under oversight of somebody who is registered. So that may help to structure the workforce for your clinics and stuff. So worth having a look at. There is additional talk about PGDs and that kind of stuff, how that's going to work. I'm still not quite sure who's going to be signing the PGDs. I know that's something that we have to do in practice, that we have to sign the PGDs to make sure that patients can have their vaccinations. We will surely have some more details of that coming soon. And then additionally, it talks about further resources that are coming, and also the fact that unfortunately there needs to be a workforce return done. So what this is basically asking for is a couple of questions. So how many vaccines could your PCN grouping deliver? And then additionally, how many vaccinations could the PCN grouping deliver additionally if they had more staff that can vaccinate and more staff that can do the administrative stuff? So looking at those two key requirements, and that's a quick survey, and that has to be done by Friday. So if you're doing this, you've got to crack on. I mean, that's 2 days by the time you're watching this, so that's not a short time. Staff training should be covered within the e-learning packages that's coming. It doesn't specify anything more than that, and I know that the cost of staff training is a question that many people have brought up, and there is quite a significant number of mandatory stuff that needs to be done. You'd hope that most people, that should already be done with their CQC updates and all the other kind of training that we're all having to do on a regular basis. But it's important to recognize that, and particularly if you're upskilling staff, then there's obviously that training that needs to happen. Indemnity, so it does talk about indemnity. So first of all, that it is covered under CNSGP, so the Clinical Negligence Service for General Practice. It is absolutely covered by that, both for staff and for vaccinating non-registered patients as well, including your own staff and that kind of thing. And that basically you're covered. The one thing that is not covered, however, is public and employers' liability will not be covered under CNSGP. So you will still need to make sure that is existing for the sites that you have for vaccinations and things. Then goes on to Annex B. Now, Annex B is just really brief, to be honest. It's the requirements that you have to have for the mandatory training in order to do the vaccinations. It just lists basically everything that needs to have happened. It's a pretty big list, I'll be honest, but as I said, most of it should have been done as part of existing training and onboarding for staff and that kind of stuff. There obviously may be some elements that need to have updated on a regular annual basis, so there's a couple of them that have to be done in the past 12 months. And then there's a non-vaccinating cohort piece of information there. So that's the main letter, the kind of the next steps of what you need to do to crack on. This leads into the service specification document, which is what we're going to go through now. This is a large document. I apologize for this. I did not create it. I'll make that very clear. And there's a lot of information here. I will not be covering every single point, because to do that, we'll need about an hour and God knows how long. But I will pick out some of the key parts for you so we can have a look at that. It does start off with the standard stuff that you see in most NHS England documents, the title, all that kind of thing, as well as equality surveys, introduction. There's some nomenclature it talks about as well. So where we get commonly used terms, here we are. So it talks about the commissioner, and in relation to this is NHSE. It talks about collaboration agreements. So this is an agreement that you must have established, and we'll come to that in a second. Designated site is basically where you're going to be vaccinating patients from, and process similar to that. GP practice basically is a member that's got a GMS, APMS or PMS contract, and various other things. PCN grouping is just one to be a little bit clear on. So the enhanced service, although this is for practices to sign up to, those practices do not have to be necessarily part of a PCN. And they don't have to be members of the same PCN. This is to allow flexibility to provide geographical support in terms of trying to vaccinate patients and things. So we're going to start with various different aspects. I did skip a few of these, so I guess just to be aware of the main ones in terms of the introduction. This is the one where it does specify in 1.6 basically that it is 8 till 8, 7 days a week, and that it does include bank holidays. It does state that this is under section 7A, so this is this weird section, so it's an enhanced service, but not a NES, not a DES. Yeah, you've all heard me talk about this before in the past. And 1.7 is the one that states that it doesn't have to be part of a PCN in order to join to the enhanced service for the COVID vaccination. I'm going to jump to section 3, because I've already covered the commonly used terms. And in 3.1, this is important, that the enhanced service is valid from 8th of December 2020 till the 31st of August 2021, unless it's terminated by the coming sections and stuff. So that's key. So we're talking over 8 months of an enhanced service that will need to be done. In terms of terminating it, so it specifies how it can be terminated. So that's if it comes to an end. If NHS England basically says they don't need the general practice to do so. If NHS England terminates it and they have to give 42 days notice to the practice to do so. And similar things. Yeah, it explains it there. Next up is 3.4, and you can only vaccinate patients that are set out in the schedule, which is in section 9.2, which we'll come to later. If you vaccinate patients outside of those cohorts that they are specifying, you may not get paid for it. And they don't want that to happen because they also see that as an element of wasting vaccination. So important to remember, you do have to vaccinate only the cohorts that are able to be vaccinated. It may seem obvious, but important to remember because we are going to have potentially people wanting this when they shouldn't necessarily or be able to have it straight away. Section 3.5 specifies that the responsibility of the vaccination is not just to the practice or to the area where it is being administered from, it is to the entire PCN grouping. So it's important to remember that the responsibility is considered joint. So that's a key part that I would recommend that most places are aware of. So the rest of them kind of talk about common things. So yeah, we're going to skip the next few ones. 4.1. So you have to sign up by 11:59 on the 7th of December, unless the Commission agrees otherwise, which I imagine is going to be very minimal reasons. You're going to have an exceptionally good one in order to not sign up outside of this date. And interestingly, that it may not be offered after that point. So there has been some comments made that this won't be offered after, so you can't think that I can sign up later if I want to, kind of thing. No, because plans will most likely be made to provide coverage to the rest of the population that don't sign up to enhanced service. So therefore, the funding may have gone by that point. 4.2, you can only administer it from a designated site unless there's significant reasons not to, i.e. if the patient's bedbound, that kind of stuff, I'm assuming from what I can see. So important to recognise that they want this done within the locations that have been approved. That doesn't mean that may not change. I'm going to come to that part a bit later on, but important to be aware of that. 4.3 sets out the payment structure. We're going to come to this. So this is explained actually a little bit more detail later on. But basically, in order to join the enhanced, payment is made as long as you join the enhanced service, and you have to enter into it, including the variations and updates. You have to comply with the requirements of the enhanced service, and you have to complete the course of vaccination to the patient in order to be paid. Kind of obvious in that respect. Section 5 talks about collaboration, and basically this is saying that by agreeing to the enhanced service, you agree to report back to NHS England or various people to make sure they've got the information that they need. This includes sharing information, sharing resources in terms of what you've got of audits of the stock that you've got, for example, that comes up, and also to various other things as well. Sharing your clinical protocols if they're asked for them, communications, etc. It's fairly self-explanatory, that particular section. Collaboration within the PCN grouping. So there's an actual section talking about that you have to collaborate with people within your PCN grouping, and that needs to happen. You need to sign a COVID vaccination collaboration agreement. So this is an agreement between the practices within the grouping. And there's elements of this, including sharing patient information from records, so sharing your records with other practices, audit of activity and stock, so that you have to be able to share that across the areas and that you've got that information available. Communicating with patients, so you've got shared responsibility of doing that. How to share staff, so how are you going to, share your staff with each other, really? That needs to be discussed. So where are we? Here we are. Sorry. And how the finance is going to be shared as well, because when we'll come to this, only one practice within each PCN grouping will be paid, and then those finances will need to be shared between them. And then the arrangements for designated sites, subcontracting, leads, or CNSGP, all that kind of stuff is detailed in this particular section. So do have a look at that. But this is basically what should be included in the COVID vaccination collaboration agreement. There is the commitment there will be a template version of this published soon. I'm recording this at 9:03 in the evening. I've still not seen one come up on the website. It may come up later on. It may come up in a couple of days' time, but that's important that you can use that and hopefully share that. And it does also talk about using an additional system called the Foundry System. I don't know what this is. I've been trying to figure this out and I can't quite yet. But you may need to submit information through the Foundry System. That's the only reference I found to that. So if somebody smarter than me knows what that is, please feel free to share that. Stick that in the comments below so we can all learn about it as well. Myself included. I'm happy to share that on social media afterwards once we've been done. So Section 6.7 is a reminder of the responsibilities in terms of what you should be and should not be doing. It's pretty self-explanatory. You have a read. So planning clinics according to vaccine supply, coordinating staff requirements, ordering vaccine requirements, receiving safely and storing it appropriately, and amending clinic schedules if there's disruption to supply, etc. That one makes me slightly nervous because obviously if you're setting up clinics and then have to change everything because of the supply, which we don't know, that's potentially a lot of logistical challenges, efforts, and potentially wasted money. Site designation. So theoretically, everyone should have already designated to have a designated site already, although I know, unfortunately, that hasn't worked out in practice in many areas that still having to go through a process of finding further sites and stuff. So this just gives a little bit more information that the process should be completed, etc. The one part I did want to pick up, so a lot of this is very similar to the previous documents, but section 7.9, which is something interesting, whether Commissioner requires GP practices to put in place any reasonable security requirements regarding the vaccine and designated site. The GP should make sure all reasonable efforts to ensure these requirements are put in place as soon as possible. I must admit that one makes me slightly nervous because we don't know the implications of what these sites are going to be looking like, whether we're going to have excess demand, whether we're going to have protests. These are potentially going to be variable as well across the country, and putting that sole responsibility and cost of that responsibility on the practices to bear, that's a little bit cheeky in my mind, because that potentially is something that may make those sites unmanageable. So that I must admit I didn't feel too good about that particular section. Subcontracting arrangements. So these basically are to identify that if subcontracting was to be done, just to confirm that they are all signing up to the exact same principles and ideals that is set out in the enhanced service. So they have to comply with NHS or EU regulations. And as long as they comply with the exact word is primary medical services, legal and contractual requirements, then it's unlikely NHS England is going to have an issue with that. But I must admit, does that mean it has to be by another practice, or could it be by a non-practice entity? I'm not quite sure. Nottingham's looking at having a system-wide effect, so does that fit that subcontracting element? Don't know. Keen to know that one. Service delivery specifications. This is section 9. This is the largest section and it's the bulk of this document. So buckle up. We're going to get cracking with this one. If you found this useful so far, please make sure you leave a like and definitely subscribe, but let's get cracking. So yeah, various parts. So section 1 says that you've got 10 days notice once this all starts effectively, and you should have at least 10 days before it all starts. Now, whilst I'm recording this, one of the vaccines has just become available. So whether that constitutes as notice, because that has obviously come through the BBC, and we've now, I believe, had the official information in the House of Commons by Matt Hancock. Interesting to know if that counts as the start of the clock of the 10 days, but we will obviously find out soon. Section 9.2 then lists the eligibleness of patients, and that you must vaccinate these both eligible patients only and in the order of priority that's set out by the document itself. And when we come to that, here you can see, so first and foremost, older adults in residential care homes and care home workers, all those aged over 80 and over in health and social care workers, all those 75 and over, 70 and over, and it goes down from there into different stratification of risk and stuff. Interestingly, it doesn't say basically all those age 50 years and over will be the last cohort. It doesn't mention anybody under the age of 50 will be getting this vaccination in this, apart from, well, no, it doesn't. I thought there'd be certain health conditions that would mean that you get it. It doesn't. Ethnicity isn't covered in this. I know that's been a cause for concern for some people, that they thought that would obviously be irrelevant, but it doesn't appear to be. Section 9.3, nothing really much to say on that one, but section 9.4 to do. You only get paid for above unless you've been able to prove the exemptions. So there are some exemptions, and we'll come to those a little bit later on. But you basically have to make sure you've tried to contact all the patients and get them vaccinated. Section 9.54a states that, so here we are, section 9.5. Here we are. Must offer vaccination to patient in accordance with paragraph 2, and you have to ensure that you've got all the various different things set up. So the call and recall service, that they're actively cooperating with the recall service and support high uptake of the vaccine. Here we are, section 9.54a, that the person doing the consent, it must be informed consent by a registered healthcare professional, and the patient consent to the vaccination and the name of who's given it, and everything must be recorded in a point of care system in accordance with law. The interesting thing with that is it doesn't specify it has to be a GP, which is what we were originally potentially told. So that is a change. And potentially this can be any of the healthcare groups that we saw earlier. So that does improve and increase the accessibility of consenting patients and stuff. Section 9.57. So important to know that the patient receives a complete course of the same vaccine. So you can't give them one and then give them the second one, which is a different vaccine. That can't happen. It needs to be the same vaccine that is administered to the patients and stuff. Section 9.510 does state that patients can be provided with a printed copy of the manufacturer's patient information leaflet, which I think is good. And we heard earlier that those will be provided to the vaccination centres. You're not going to have to print them off yourself. I don't know why we can't just send them an electronic version. Yes, there's definitely some people where you're going to have to provide printed, fair enough. Electronic, just send it out to everybody when they get booked into the clinic. Nice and easy, done, sorted. Anyway, let's crack on. Section 9.511, administration with vaccinations and other vaccinations. This is a chunky paragraph, I must admit, but it basically talks about the fact of how you can administer it with other vaccinations that they think, as far as we're aware, it's safe. Obviously, this is a novel vaccination. We don't know much about how it works, but with inactivated vaccinations, it should be okay. With live vaccinations, it may affect the ability of it to work. So it is worth having a read of that section in particular, because it's pretty big, to be honest. But effectively, they're not quite sure what the implications are. It does... where are you? In such circumstances, patients should be informed about the likely timing of potential adverse events related to each vaccine. I'm not quite sure what that means, to be honest, because how are we meant to know what the potential complications are until we start vaccinating people? And if that means about the other vaccinations that they may have, clearly we would be doing that anyway, I would imagine. I don't know. Anyway, cracking on. 9.6. Record as per guidance in the previous letter and video. So this is about how you record the vaccination. There's particular things you need to put in, like the location of the vaccination given, name of the person giving it, expiry dates, all that kind of stuff. That's in the previous letter, and the links there if you want to have a look at it. There's a lot more stuff, obviously, but have a look there. And section 9.7 is the emphasis that the second dose has to be done by the same provider. This is to try and reduce, I guess, inaccuracies and stuff, but under exceptional circumstances, it can be done by a separate provider, but it should ideally be the same place that the patient's coming back to have their second dose. In terms of persons administering the vaccination, and that's what section 9.81 and 9.82 details, both in terms of the person who is all healthcare professionals administering the vaccine must have and what's entailed there, and then all other persons administering the vaccine must, and so these are the other categories that we saw, if they're being upskilled to do it, what they must have done. As I said, this is outlined in Annex B of the previous letter, in the two sections there, so have a look at that in more detail for the training that's required. Section 9 mentions about the storage of the vaccine, how that may work, and what equipment you need, like thermometers, what type of thermometers, keeping the cold chain, the appropriateness of all that. It doesn't give the specific detail for each individual vaccine because we don't have knowledge of which one we're having, and obviously it is different based on which particular vaccine. Do feel free to check out our previous section where I covered a lot of that with Andy, and I'll put the links to that and all of the other streams that we've done down below in the show notes, so feel free to check those out. Section 9.10 talks about making sure you've got accessibility to all patients in terms of the Equalities Act, and just obviously that's an obvious category that we must comply with anything anyway. And 9.12 talks about equipment loans from CCGs, so that they should be available equipment if you need it, and if you should be able to give them back to the CCG in appropriate condition once you've used it. And I'm guessing this is things like deep freezers, that kind of stuff if needs be, but obviously other places may have other ideas on that. So that's section 9, that's the service spec itself. Monitoring and reporting. cracking on. So monitoring and reporting, that talks about it in terms of what you need to do and how you need to do it. Key point that you need for section 10.10 to record adverse events and have a process for how to do that, and also do the yellow cards. Something I know many of us potentially don't always remember to do. Yeah, I don't know. Maybe you're better than me than I am, but obviously this is a new situation, and this will be something that does need to be done keenly. So having a process for that in place, think about that, how you're going to do that, how's that going to work, and potentially how are those in practices that aren't vaccinating going to be able to pick up when patients have had their vaccine, and to be aware of those potential things later down the line if that's relevant and stuff. This is probably the section many people are keen to know about, which is the payment and validation section. So a payment of £25.16 will be applicable to the practice once they've completed both vaccinations, so we've mentioned earlier. So it's £12.58 per vaccination. There is no plans for you to get the payment after the first vaccination. So there is that time frame we talked about in the cash flow element that we mentioned earlier. So the key points to get the payments is covered in section 11.2. So in order to have the patient, when you see the patient at the time of the vaccine, is all the following must apply, except for the qualifying reasons. So the GP practices use the specified vaccines by the JCVI, so you can't use a non-registered vaccine. Patient claims announced an authorized cohort at the time of the vaccine, so they must be in the relevant cohorts. Vaccine has been recorded in point of care system, and the practice is not received and does not expect to receive payment from somewhere else. So if you're getting it from another service, local enhanced service, mass vaccination, that kind of stuff, important to recognize those. 11.22, single practices. You must have a single practice that is getting the payments both for non-registered patients and also for registered patients as well. And then that money should flow from that practice to the rest of the PCN groupings. Logistically, I'm guessing this is the case, and it's to do with ODS codes as well, I believe, to make sure there's easy reconciliation and stuff. 11.3, exceptional circumstances. So this talks about what you do if you can't do the second vaccination. And simply put, so there's patient elements and then there's practice elements in relation to the patient being changed. So the patient immediate ones, these are the same as the earlier documents. So they have an allergy, they are end of life, or they have died. And so if either of those three happen, then you don't have to have obviously done the second vaccination. In terms of patient changing circumstances, so patient choice, so if the patient has definitively chosen not to have the second dose of the vaccine following a discussion with the clinician, it doesn't specify what type of clinician. It doesn't state GP. I'm going to hold NHS England to that. It doesn't state GP. It says clinician. So important to recognise that, and important to document that clearly. No response. The patient did not book an appointment after receipt for the second dose, and has made 2 separate attempts to contact the patient, and a period of 60 days has lapsed. Really don't like that and. It's the one and in this document I hate the most. But that's obviously important to recognise that those 2 requirements apparently need to be fulfilled in order to therefore claim the payment. So you have to try them twice. Okay, that's not the end of the world. That's a phone call, text message, phone call, letter, text message, letter, that kind of stuff could be considered appropriate, I would assume. Make sure they're documented to help with that. If the patient is moved, then you know outside of the area and stuff, and if they're not accessible, for example, if they've been admitted to hospital and therefore you can't vaccinate them because they're now in a hospital environment, for example. And the last one is if there's no vaccine supplies. It's important to recognise that part as well. 11.4, you need to keep a record of who is exempted and make sure you've got that. I would definitely recommend you've got that available to yourself. 11.5 is further clarification on the payment terms. So basically, this is the more detailed stuff you have to comply with in order to make sure you're paid. So they've been done. You've got the vaccination collaboration agreement in place. They comply with the requirements. They enhance service available to the commissioners if you need to make the returns, and all information supplied when they ask for it. Basically, fair enough. That's kind of anticipated, to be honest. 11.8, let's crack on to that. So if the commissioner makes a payment to the GP practice under the enhanced service, and so this is basically how NHSE can claim back payments if they've made the wrong payments. It's a little bit mean worded, if I'm being honest, because it's quite prescriptive, and what it doesn't state is what happens if they haven't made the payments in time. So there's very much a tone here that says that they will reclaim the money. Fair enough. If it's been paid inappropriately, that's acceptable. That it can be taken from GMS and personal from the core funding, basically, if unable to be recovered through other means. As I said, what I don't like about these sections is that there is no comment on what happens if payments are made late. It's very much one-sided agreement, this part, and I feel that there should be something in there about late payment, because we have seen that happen previously. It does state that if there's an error, then the practice will be paid the amount that is due. And it does state that post-payment verification process will be done by NHSE rather than by the practice. I'll be honest, I'm slightly skeptical on that. I anticipate many practice managers and areas will going to be having to put lots of additional claims in to reclaim money because of accountancy errors and that kind of stuff. Hopefully I'll be proven wrong. Okay, I'm going to stop being skeptical now. Section 12, withdrawal from the enhanced service. So this states about what the process is in terms of that. If a practice wishes to withdraw, they must provide written confirmation to the Commissioner, NHSE, and 42 days worth of notice. That's important to recognise. I think that's in some ways reasonable. In some ways it's a challenge. We'll come to why that's a challenge in a second. Section 13 makes comments about variations to the enhanced service. So because this is a novel situation, because it's an evolving situation, clearly there has to be some elements of this being able to change. And basically section 13.2 makes this clarity of what those changes can be. So pretty much anything, they'll be done on the website and notified through the bulletins, which is why you do need to register to the bulletins on a regular basis. And the 42 days doesn't apply in that respect. So my issue with the earlier point about the 42 days is if a contract variation that comes through, that means that a site or something is no longer able to do the vaccination process, then they still have to continue to provide the vaccine for 42 days to the population. But if they can't comply with the new regulations, how is that covered? How is that sensible? How does that work even? And how does that work from the payments? Because it states earlier, if you're not complying with the regulations, you don't get paid. It does state later that if you aren't, that you will be paid for the work that you've done, as long as it's been appropriately done so. So hopefully that means practice will still be paid. But more importantly, this creates a potential vacuum in terms of vaccinating patients, because if an area can't vaccinate because of an amendment that's happened, and there could be logistical stuff around this, how will that work? And I really would like clarification, hopefully from the webinars, in terms of what that looks like. The final part is Annex A, and this relates to what happens with changes with practices if they sign up to enhanced service. And the three key areas this happens is if there's a closure of a practice, if there's a merger of a practice, and there's a new starting the practice. It basically sets out the terms for that, which are understandable and reasonable from my perspective. So I think that's something that you can anticipate easily. So AGP learners, I hope you found that useful and effective. This has basically been a whistle-stop tour talking about the enhanced service, the actual document that's available, and the letter in terms of the next steps document of what you need to be doing to plan for this. As I mentioned earlier, but if you're watching this the day it's come out or not, you've got till the 7th of December at 23:59 to sign up to the enhanced service. And those are the things I think you need to be aware of. I'm keen to know if there's further information we will get in terms of what this looks like, if you're planning to delegate this or work with wider systems, for example, particularly for myself. I know we talked about, myself and Andy, about how the Nottingham plan was to have a local system, and does that mean we can sign up to enhanced service and use those funds and resources to support our local aims, or does that work through a different way, or does it not work at all? We will find out. If you do have any comments or questions, feel free to let me know. More than happy to try and answer them as best as I can. Make sure you subscribe. Definitely leave comments if you found this useful. I really hope you have done. And as always, EGP Learning is here to help save you and your patients time by taking answer your primary care and learning. I'll catch you in the next episode.